So it's a pleasure to be here, and I appreciate the invitation. Just a proposed study is of immunotherapy and combination with IORT. Just this side as a background, Ohio State has been doing intraoperative radiation therapy since 1990. I've been a part of that for the last 6 years. And obviously we're doing it in multiple different sites. Currently, what I'm going to talk about specifically is what we're doing in head and neck. I think a few of the talks that happened before us said it best. This is a team approach. It's important to understand that, and this is a tool. And in so understanding that, the idea that there has to be multiple components in order to help our patients with these difficult diseases, especially the refractory components, the components where we've tried a particular modality and things have failed in that salvage setting. So the standard of care for local regional recurrent head and neck cancer is surgical resection followed by some sort of adjuvant therapy. And this was, and I'll talk about this in a few minutes, there was a phase 3 trial that showed this. It was done in France. However, the local control rates alone for surgery alone are in the 20% range at 2 years, which is unacceptable. And so local control failure remains the primary site of recurrence, and overall prognosis in this patient population is poor. So the idea here is, can we utilize IORT in combination with other things, not just IORT alone, obviously with good surgery, but also with potentially systemic therapy. And towards the end of the talk, I will talk about our efforts with immune therapy or immuno-oncology. So the study that I mentioned was a phase 3 randomized study that looked at surgery in these patients with recurrent head and neck cancers versus in the outback observation versus adjuvant 60 gray of radiation with concurrent 5-FU and hydroxyurea. The data was pretty compelling. The local regional control at 2 years, about 60%. And these are numbers I want you to remember, not forever, just for a few moments. And about 20% in surgery alone. In the disease-free survival region, we're looking at around 40% and 20%, and we did not reach overall survival benefit here. Toxicity was something that was very important and fairly extreme, if you will. Almost a third of the patients had pretty severe toxicities, and it's something to remember as we move forward. And we're talking about RTOG grade 3 or larger toxicities. So in our study, what we decided to do is look back and say from 2015 onwards to see how well have we been doing with intraoperative radiation therapy, and compare those studies to these historical controls, and then see what we're doing in terms of marginal status and sort of the regular players. So during this time frame at Ohio State, or as we say, the Ohio State, which always makes me laugh, there's a story. The story behind this is there's Ohio University, and so the distinguishes. But then the sports teams start taking this, and so the Ohio State is the appropriate way of pronouncing or expressing the university's name. But out of these almost 100 cases, we had 61 that were salvage cases, and we had 45 that were squams. We had margin statuses in these, and it was very eloquently shown a little earlier. Maybe IORT is helping us for these margins, and I think that's something interesting that I think previous speakers brought up that I think needs to be studied definitely further. So 55% had recurrence, 6 had persistent disease. This is our ratio of male to female. The primary sites were oral cavity, oropharynx, and sinonasal. Most of them were treated in the primary, about a third in the neck. So we had a pretty decent distribution of positive margins and negative margins. And these are the rest of the histologies and different things that we encountered with these patients. One course of external beam, at least one course was given in 54 cases. External beam was given 2 courses in 2 cases, and then there was one case where we did external beam IORT and external beam IORT. And there are cases where we do this, but they're a handful and they're a case-by-case type of scenario. The dose range is between 10 to 17.5 gray within the operating room. And what's interesting when we look at this, and someone said this earlier, and I think it was you, Alex, you were talking about patients having a difficulty coming back for further treatment after. And that happens to be the case at Ohio State as well. We treat about a 2.5, 3 hour catchment, a radial catchment in terms of patients that come to us. With this, after they get their treatments, often they cannot come back to us. And so often because of logistics, they can't get further post-operative external beam radiation therapy because the basic teaching is you need about 66 to 70 gray total. So if you're giving 10 to 15, and if we use a back of an envelope calculation, an estimate, if you will, that's about 20 to 30 gray. So you need to be able to deliver somewhere between 40 to 45 gray additional external to get the dose required. So often, unfortunately, our patients didn't come, and even less frequently, they got chemo-RT. So when you look at this, 2/3 of the patients only got surgery followed by intraoperative radiation. And I want you to remember this as well also just for a couple of minutes, because the thought process here is despite all of this, our data was pretty good. We had 60% local control at 1 year, we had 62% overall survival at 1 year, and 40% overall survival at 2 years. When we look at squames versus non-squames, in terms of median, non-squames did better. However, those numbers are pretty small, but they're still there, and also positive margin versus negative margin, which you would expect. So when you look at this, we're getting fairly good outcomes for our patients, and yes, it's retrospective, and yes, but these are the worst comers, if you will, because they don't have a chance to go anywhere else. They have to come to a tertiary center like ours in order to take care of them. So if anything, it's biased towards the worst players. So when you started to think about this, and this is just a pictorial representation of what we just saw, and margin status also playing important, positive, negative, as I just mentioned before. When we started to think about this, you start to think and say, well, can we think about treating these folks a little differently? And this is where the clinical trial started to come in. But before we get to that, the toxicities were marginal. I mean, we had one carotid blowout, but after discussion with our surgeons, we really felt like it was predominantly because of the graft, and that we weren't protecting the carotid after. So overall, we had fairly reasonable toxicities that we can deal with and we can help our patients through. So that's important to note, and that's something I think that should also be at the top of our list in terms of, especially in the head and neck world. So in conclusion, we have a population with difficult cancers, overall survival dismal, and yet with intraoperative radiation therapy, and 2/3 of them as the only adjuvant therapy, we were able to get fairly comparable results to the phase 3 French trial. So perhaps this decreased toxicity and decreased duration is something real. So the idea in the future is to say, well, we need to pool all of the head and neck data that we have and do a proper meta-analysis if possible. And we're working on this. And then also look at prospectively further trials. And could adding immuno-oncology or IO be preoperatively to the IORT improve upon local control and progression-free survivals? And so this was our paper that was just published in February, so folks can take a look. But the concept is, head and neck cancers are an enriched immune landscape. So since 2016, we've probably had somewhere in the vicinity of close to 150 head and neck patients that have been treated with immune therapy at our institution. We've looked at our data, and we're actually going to be publishing this pretty soon. The response rates with IO alone in head and neck are somewhere in the 13 to 15% range. So, at best, I'm in Great Britain, so I have to talk football here, world football, not American football. But in world football, that's best a draw. That's 1 point. So can we potentially have a situation where we can work with radiation and work synergistically? And it turns out from our data, at least, if you're HPV positive, even in the recurrent setting, we're seeing about 20 to 23% response rates, whereas HPV negative is 5%. So I don't know if these drug companies are going to be happy with us because we're going to limit their their use in head and neck cancers, at least, because HPV negative, there's still a lot of work needs to be done. In any event, if we have a situation where we can potentially give radiation and provide new antigen presentation for these cancers, be it in the IORT setting or perhaps a little bit in the preoperative setting, perhaps we will increase these numbers and perhaps get a victory and get those 3 points that we're really trying to achieve for all of our patients. So recently, Dr. Di Maria and Dr. Formenti from New York came up with, and we're starting to see that different doses of radiation are not affecting cancer cells the same way. So 2-grade perfraction, we have mitotic catastrophe. However, at 8-grade perfraction, now we're looking at the Trex promoter. We're looking at different mechanisms of cell death. At 20 gray, we're looking at an immune system that's really suppressed, versus at 8 gray, where we're looking at an immune system that's really enhanced. And so this was done in mice, mind you. So it's important to understand. And this was the idea that I, together with Dr. Grusula, John Grusula, who's a partner and who's been doing IORT since 1990. He's a great resource and a fantastic person. We started to say, well, IO or immunotherapy is now standard of care in this setting. And so giving this is not, it's not sort of, mind-boggling, but what is interesting is once we give it, the idea that we can start to think about some preoperative radiation doses, either 0 gray, 2 gray times 2, which is our standard fractionation, or 8 gray times 2, as I discussed earlier. This is utilized by the RTUG 3507, which we have open at our institution, where we give 8 gray times 5 for these cancers, and in that setting, it's plus or minus pembrolizumab. So the idea here is then we take the tumors, we remove them, give intraoperative radiation therapy for 10 to 15 gray, and follow for at least 6 months with immunotherapy. And the hope is that we can shift the paradigm for patients that are surgical candidates, where we can say, that 62% that I said that couldn't get it, perhaps with immunotherapy, they may not need to get any further external beam radiation therapy. And we don't really know the answer to that. The other thing that's really exciting here is that we're really going to start to learn, because there's a component to this clinical trial that would allow us to look at correlatives and look at both mRNA, DNA, and protein. One of the hats that I wear is I have a PhD in biochemistry, so I always believe proteins rule the roost. So it's very important to follow up what proteins are doing. And so to start to learn really what's happening in these cancers from a molecular standpoint, hopefully will provide us with new targets as we move forward. I'm excited, and Derek is sitting at the room here. The Intra-op folks are going to help us fund this project. This is just some pictures of the Mobitron. I figured, the surgeons can't have all the fun. We radiation oncologists have to show some pictures as well. But it takes a village, and this is the team. Dr. Chakravarty is our chair, John Grusula, Jim Rocco is our ENT chair, Matt Old. These are folks that are all working together with Marcelo Bonomi, who's our medical oncologist, and the vision that Intra-op has in understanding how important having some actual clinical trials moving forward that really help us understand things, both at the clinical as well as the molecular standpoint. And so with that, I really want to thank everybody, and I'm happy to take any questions that you may have.